So welcome to today's lesson, and today I'm going to talk about malaria. So malaria is a common condition in Zambia, Africa. But when you look at Lusaka is one of the regions in Zambia which is malaria free, basically pronounced by the Minister of Health to say Lusaka is malaria free. But malaria is still a major problem in other regions in Zambia and Africa as a region. So, what is malaria all about? What happens when someone has malaria? This is what I'm going to discuss about today. I want basically focus on the cerebral malaria, which is more a severe form or an emergence form of malaria, but I'll just talk about malaria in general. So, how can we define malaria? Malaria is a protozoa infection of the blood, and basically it affects the red blood cells, and this is caused by the genus Plasmodium species, because we have a lot of causative organisms of malaria, which I'll talk about later on. And it is transmitted by an infected female Anopheles mosquito, and this condition is characterized basically by regular cycles of chills, as well as raised body temperature or fever basically. Apart from that, you can have other complications or symptoms or characteristics of malaria, such as you're going to see people having headaches, and this is basically due to toxins, as well as cerebral hypoxia. Patients can also present with joint pains due to ischemia, sweating due to fever, body pains due to tissue hypoxia. So these are other symptoms or characteristics that a patient with malaria can present with. So basically, that is how we can define malaria. So when it comes to the types of causative organisms of malaria, what organisms can cause malaria or give rise to malaria? So we have Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, as well as Plasmodium malariae, as well as Plasmodium knowlesi. So these are some of the causative organism of Plasmodium that are capable of causing malaria in a human being. When you look at all these Plasmodium that I've mentioned, you're going to see that Plasmodium, when it comes to Plasmodium falciparum, it causes a severe form of malaria. So someone who has a Plasmodium falciparum infection is going to suffer from a severe form of malaria, unlike the other types of Plasmodium. And this basically accounts for the most common forms of malaria condition that we see in patients that presents with malaria. So basically, these are the types of Plasmodium that can cause malaria. To understand malaria or any tropical condition to the fullest, you also need to understand about the life cycle of that particular condition. So from here, we can move on and look at the life cycle of malaria, because any tropical disease, for you to understand it fully, you need to understand its life cycle, how it moves, how the condition can still continue to exist even when the patient who suffered from that condition has already been treated from that particular condition. So this is basically the importance of you understanding the life cycles of tropical conditions like malaria. So when it comes to the life cycle of malaria, you realize that the life cycle of the Plasmodium parasite has two phases. It has the sexual phase, or the sexual cycle, sexual cycle known as the sporogony, which takes place within the intestinal tract of the mosquito, which is this phase that we'll talk about after we talk about the other phases. Then it has the asexual cycle known as the schizogony. So the schizogony, this is the schizogony cycle, which takes place basically in a human being, and this is basically found in the saliva of an infected mosquito being deposited in a human being, and then you are going to have a schizogony cycle being taking place in a human being. So on stage 1, this takes place when saliva containing the infective sporozoites is injected into the bloodstream of the human being through a mosquito's proboscis, or basically that pointed thing of a mosquito, which we call the proboscis. So it is going to inject the sporozoites into the bloodstream of this human being. Then after circulating for about 20 to 30 minutes, the sporozoites are going to enter the parenchyma of the liver cells. So once they are injected into the human blood, the sporozoites will continue moving into the human blood, whether systemic circulation or whatever circulation. Then for that is going to take place, or that is going to happen for about 20 to 30 minutes, after which the sporozoites are going to enter the lung parenchyma of the liver cells, where they now begin to multiply and infect the liver cells. So this stage is called the exoerythrocytic stage, because at this stage the sporozoites from the mosquito have not yet infected the red blood cells of this human being. So in about 6 to 14 days, so between 6 to 14 days, the merozoites are going to be released from the liver cells and are going to be released into blood circulation. So in fact, the sporozoites are going to be in the liver cells for about 6 to 14 days. From there, they are going to mature into merozoites, and the merozoites are the ones which are going to be released back into the blood. So the merozoites are going to be released back into the blood circulation, and then here they are going to seek out penetration of the erythrocytes, basically the red blood cells. So this stage is called the erythrocytic stage, because at this stage now the merozoites are seeking to now penetrate the red blood cells. That's why it is also called the erythrocytic stage. So within the erythrocyte, or the red blood cells, the parasite can go through a series of developmental stage, and these developmental stages or form are known as trovozoite stages as well. So you're going to have, so depending on the species, it is going to enlarge, divide into segmented stages known as schizons. Once the merozoites enter the red blood cells, they undergo developmental stages known as trovozoites developmental stages. But once they enter, they are going to divide into segmented stage known as schizons. Then the schizons are going to divide into individual. They are going to rupture. The schizons are going to rupture the erythrocytes, and merozoites are going to be released back. So once the schizons develop, they rupture the red blood cells. The schizons, as they rupture, they release back the merozoites, which are released back into blood circulation. So these merozoites then seek out an infected erythrocytes, and then the cycle is going to continue in this manner. So as you remember from the infected liver cells or liver parenchyma, merozoites were released, but what entered the merozoites were the sporozoites. So the merozoites were released from the liver cells. The merozoites seek out uninfected red blood cells. They undergo developmental stages to become schizons, and then schizons they rupture again, releasing the merozoites, which are the infective form of the uh, uh, which are the infective form of the plasmodium. So as this cycle is taking place, where the merozoites continue now attacking uninfected red blood cells, and the cycle continue happening, this is the point when this infected individual is going to experience now several chills, as well as raised in body temperature, because you have a lot of red blood cells which are being which are being broken down or which are being attacked by the plasmodium. But after several erythrocytic cycles have taken place, some of the merozoites are going to transform into sexual form called the macrogametocyte, which is the female form of the plasmodium, as well as the microgametocyte, which is the male form um, of the plasmodium, developing into gametocytes. So these gametocytes are then ingested. So when a plasmodium free anopheles, we are going to have a plasmodium free anopheles, which is going to take its blood meal or bite a human being which is infected, and this human being is carrying this gametocyte, which is basically the male form and the female form of the plasmodium, which we call the microgametocyte as well as the macrogametocyte. So these gametocytes are going to be ingested by this are going to be ingested by this mosquito, and it is going to ingest as well together with the trophozoite infected erythrocyte as part of its blood meal. But as it does this in the stomach of the mosquito, the microgametocyte are going to develop into between 6 to 8 flagella. So they are going to develop as the microgametocyte are ingested, they are going to go into the stomach of this basically the mosquito of this mosquito, and the microgametocyte, they develop between 6 to 8 flagella microgametocyte. They develop tails in other words, and these microgametocyte breaks free, and then they are going to penetrate the female macrogametocyte, producing a fertilized zygote. So the microgametocyte as well as the macrogametocyte are going to break free from wherever they are being held from in this with this structure or their eggs. And as they break free, they are going to penetrate or undergo sexualization, penetrate each other, and as they penetrate, they are going to form or produce a fertilized zygote. And these fertilized zygote, they are going to enter the stomach wall of the mosquito, forming the oocyst. So as the fertilization occurs, they are going to develop into okinete, and then from there they develop into the oocyst, which is basically once they enter the stomach wall of this mosquito. And later on, the oocyst is going to break free, releasing the sporozoites. So the oocyst from the stomach of the mosquito, once they develop and mature, it is going to break free, and once it breaks free, it's going to release the sporozoites. The sporozoites are then going to migrate to the salivary glands of the mosquito. So the sporozoites will migrate to the salivary glands of the mosquito, and when the mosquito takes or bites or takes a blood meal in a new host, the sporozoites are going to squeeze from the salivary gland and injected through the proboscis of the mosquito into the new human host. And then you are going to have Plasmodium falciparum schizons, which are rarely seen in the peripheral blood, being injected in this human being. So basically, that is the life cycle of malaria. And so it's basically having plasmodium being injected in a human being, where attacks the liver cells, matures from the liver cells, they are released, ruptures, releasing schizons, and then you have merozoites again coming out. They attack red blood cells. Red blood cell continues to be broken down or hemolyzed in that process, and then the patient is going to have fever and chills, body chills, body aches, and joint pains being seen. But as this erythrocytic stage continues, as more red blood cells are being broken down or destroyed, you are going to have now the sexual form developing, where the microgametocyte and the macrogametocyte develops. From there, another mosquito takes a blood meal, it ingests these gametocytes, and then they go into the stomach, they penetrate each other, and then from there they penetrate the wall of the mosquito, forming an oocyst, and oocyst later on breaks free, releasing sporozoites which go now to the mosquitoes salivary glands. From there now it will only take another human being to be bitten, and this human being is a definitive host. This is where malaria can manifest in a human being and not any other animal. So a mosquito just acts as an intermediate host where the plasmodium can undergo development, but for this condition to manifest, it needs a human being, which is a definitive host in this case. So basically, this is the life cycle of malaria. When it comes to the pathophysiology of malaria, you realize that in all forms of malaria, the spleen and the liver enlarges as erythrocyte are sequestered or broken down by fixed mononuclear phagocyte system. Then here the organs of this system, which is the liver, the spleen, as well as the lymph nodes, are darkened by macrophages filled with hemosiderin as well as malarial pigments, and the end product of parasitic digestion of hemoglobin. So here there will be adherence of the infected red blood cells to the microvascular endothelium in the falciparum malaria, which has two consequences when this occurs. The first thing is that the parasitized erythrocyte or erythrocyte containing the plasmodium is going to attach to the endothelial cells which do not circulate, which are going to be prevented from circulating. So the patient with severe falciparum malaria have few circulating parasite in the bloodstream. That is why it is hard to for malaria RDT test to come out positive with someone who has a falciparum plasmodium in their bloodstream, because they are going to have less of the infected red blood cells circulating in the peripheral blood. So if you puncture someone's thumb, likely the RDT is going to come out negative. Meanwhile, this patient has falciparum malaria, and this is the severe form. So you just see physicians putting this patient on anti-malarial drug, even though the test has come out negative, because of the nature of the plasmodium being found in the blood. So secondly, you're going to see capillaries of the deep organs, especially of the brain, becoming obstructed. And because they are obstructed, this leads to ischemia of the brain, the kidney, as well as the lungs. So the brains of the person who die from cerebral malaria show congestion as well as thrombosis of the small blood vessels in the white matter of the brain, which is rhymed with edema as well as hemorrhage. Apart from that, you're going to see obstruction of blood flow in the kidney. This is what produces basically acute renal failure to patients who have malaria as well as developing renal problems. Then apart from that, while intravascular hemolysis leads to hemoglobinuric nephrosis, which is black water fever, in the lungs, there will be damage to the alveolar capillaries, which produces pulmonary edema as well as acute alveolar damage. So basically, this is what happens to someone who has been infected with malaria, and those are some of the clinical manifestations that you are going to see in the disease process of malaria. When it comes to signs and symptoms or clinical manifestations in malaria, you are going to see symptoms such as fever due to presence of the parasite in the blood. Apart from that, there will be headache due to toxins as well as cerebral hypoxia. There will be joint pains due to ischemia, sweating due to fever. Apart from that, there will be chills due to interference with the temperature control center in the brain. And then the patient can also present with body pains due to tissue hypoxia, as well as acute gastroenteritis due to parasitemia. Then apart from that, other clinical manifestations or symptoms that can be seen, you see someone presenting with nausea. This is because of the GIT being involved in the disease process. Apart from that, there is vomiting, dehydration can also come in. Diarrhea can also be seen in someone with malaria. There's extreme weakness, and this is due to tissue hypoxia. There is also severe anemia, which can be seen in malaria, and this is due to hemolysis. Apart from that, jaundice can also be seen, which can come from increased hemolysis of red blood cell. If you go back to our life cycle, you understand why there is increased hemolysis of red blood cells. There is also drowsiness as well as the lethargy, which can be seen, and this is due to cerebral hypoxia. And then apart from that, respiratory distress due to pulmonary edema. Then unconsciousness can also be seen due to interruption of blood supply to the brain tissue, which can be due to occlusion of brain capillaries. Apart from that, hepatosplenomegaly can be seen due to excessive destruction of RBCs, as well as sequestration of blood in the spleen. So these are some of the symptoms that can be seen amongst others in a patient who has malaria. So when it comes to disease progression of malaria, everyone progresses or undergoes these stages in whenever they have malaria. So these stages are called the Riga stages of malaria. So Riga is a common manifestation of malaria, and it undergoes the following stages. The first stage is the cold stage. So during the cold stage, if you have malaria during this stage is characterized by shivering. This is the period when you shiver a lot and there is an intense feeling of cold. The lips as well as the fingers are cyanotic, they look bluish, they are dry as well as looking pale. And in children, the child may also have seizures, or they may experience seizures during this cold stage. And this cold stage lasts about 15 to 60 minutes or 15 to about an hour. And this is a period when this patient just needs to sit on the direct sunlight, because it makes them feel better. But from there, the patient is going to move to the next Riga stage of malaria, which is the hot stage. So during the hot stage, this stage lasts about 2 to 6 hours, and it is caused by the temperature, which could be above 41 degrees Celsius. And this is characterized by a full bound pulse. There is also a dry burning skin. The patient feels extremely warm, and there is intense headache as well as nausea and vomiting. So the stage when this patient presents with nausea and vomiting, but with a burning skin as well as intense headache, just know that the patient has presented on the second stage of malaria, which is the hot stage. Then from there, if the patient is given enough treatment, proper treatment, and you are controlling the malaria, the patient is going to move to the last stage of malaria, which is basically the sweating stage. So the sweating stage lasts about 2 to 4 hours, and it is characterized by profuse sweating. The temperatures is the reason why the patient sweats profuse is because the temperatures they fall rapidly below norm, and the patient may even go into a deep sleep. And on waking up, the patient feels very weak, but they feel normal. So this is the sweating stage, meaning at this point, this patient is getting healed from malaria and they are going to be okay. But if a patient doesn't be given proper treatment and the condition worsens, the patient cannot pass the hot stage. They are going to die. They won't reach the sweating stage. But if a patient reaches the sweating stage, meaning this patient is getting better, is getting healed. So basically, those are the Riga stages, the stages through which each patient who has malaria undergoes, except if the patient presents with cerebral malaria, probably they will come into in an unconscious state, meaning you are going to manage them using intervention, emergency intervention. But a patient with any other type of malaria, you just manage them using general nursing management. So when it comes to management of malaria, of course, as you're managing any condition, you need to start with diagnosis. And the diagnosis involves you at least coming up with 5 investigations. And investigation starts with history taking. So basically, during history taking, the patient will present with history of fever. Apart from that, during physical examination, the patient is going to present with maybe a generalized body weakness. Apart from that, maybe the patient will also present with a raised body temperature above normal, meaning above 37.5 degrees Celsius. And from there, the patient we can do other investigations like the RDT. So the blood slide for malaria parasite, it is going to come out positive. Then when you get blood for full blood count, it is going to show low hemoglobin levels, as well as leukocytosis. There will be increased white blood cells, and then there will also be raised erythrocyte segmentation rate. Apart from that, you can do a lumbar puncture to rule out meningitis, because meningitis also presents similar with cerebral malaria. So you need to rule out meningitis as well. So apart from that, you can do a blood glucose estimation for patients with altered level of consciousness, so that you rule out whether this patient is unconscious because of hypoglycemia or unconscious because of malaria. So these are some of the investigations that can be carried out in malaria. Then from there, you can give in terms of treatment, you can, if the patient has uncomplicated malaria, you can give Coartem, which is artemether, lumefantrine. Artemether is 20 milligrams, as well as lumefantrine 120 milligrams. So this is the drug of choice in uncomplicated malaria. But children with a weight which is less than 10 kg, as well as pregnant women, should not be given Coartem. This means that the first line or drug of choice is Fansidar to women, especially with the uncomplicated malaria. You don't give them Coartem, because Coartem can disturb replication of DNA in someone who's pregnant. Therefore, um, you can give Fansidar. But if the woman is in the first trimester, meaning the first 3 months of pregnancy, you do not give them Fansidar as well, because Fansidar can also disturb replication of during growth of the womb. So it can disturb DNA replication, and then you are going to have a child being born with congenital abnormality. So you do not give Fansidar, but you are just going to give either quinine or artesunate to manage that type of malaria. So you need to know all those things as a medical practitioner or as a patient taking malaria anti-malaria drugs, to say you don't take Coartem if you are pregnant, as well as you do not take you only take Fansidar, but you also do not take Fansidar if you are in the first 3 months of your pregnancy. In that case, the only other drug that you can take is quinine or artesunate. Then apart from that, the other drug that you can give in complicated malaria is either quinine or artesunate. But right now in Zambia, artesunate is being given in to manage complicated malaria, and artesunate you can give 2.4 milligrams per kg body weight. And if it's quinine as well, you can give 10 milligrams per kg body weight, and this is diluted in an equal volume of water. So you see that those are the drugs that can be given in severe complicated malaria. Then apart from that, you can give supportive treatment like analgesics like Panadol, which can be given 1 gram TDS for about three days. Then folic acid can also be given 5 milligrams once daily for 14 days. Then if the patient has presented with cyanosis, difficulties in breathing and other things, or in short complicated malaria, can give oxygen if it's an adult, 3 to 5 liters per minute of oxygen through a nasal catheter or any other method. So those are some of the drugs that can be given in to manage malaria. But when it comes to nursing management of malaria, you can manage the patient with malaria. If the patient has malaria which is not complicated, you can just generally manage these patients. A patient who presents with cerebral malaria, you are going to use emergency interventions meaning you need to start with resuscitative measures, which is the air or breathing, circulation. If you want, you can also add the D, which is drug in resuscitation. And then from there, you move on to the general management, bring in the ibuprofen. But as you manage a patient with the uncomplicated malaria, you're just going to use the ibuprofen, the general nursing management of this patient. Then when it comes to general nursing management, in your management, you need to talk about management during the cold stage, the hot stage, as well as the sweating stage, because those are also part of management when you're managing a patient with malaria. So generally, uncomplicated malaria, I've said you use a prophenem, which is general nursing management, but I've said also bring in management during the cold stage, hot stage, as well as the sweating stage after your environment. So during the cold stage, you realize that here you need to switch on the heater to promote comfort. You need to add the extra linen to keep the patient warm, and apart from that, you can also give you can also put the patient, honest the patient in a warm environment. Then during the hot stage, you can remove extra linen to promote heat loss. You can switch off the heater in order to cool the patient. You can switch on the fan, honest the patient in a well ventilated environment. Apart from that, you can also talk about nursing the patient during the sweating stage, and during this stage the patient has sweated and you find that linen will be soiled, so you need to change the soiled linen to promote comfort. Apart from that, you can bath the patient to remove perspiration and also promote comfort. You can offer copious fluids, as well as you can do observations on the IV lines and other things. So those are the points you can put under the cold stage, hot stage, as well as the sweating stage, and from there you continue with a profanema heading such as arrest, position, observation, psychological care, hygiene, nutrition, all those points in a profanema. If you're managing a patient with uncomplicated malaria, and if you're writing such points or such headings during your final exam, no one is going to mark you wrong because those points are well organized. If you're managing a patient with cerebral malaria, use emergency interventions, meaning you start with resuscitation, then bring in a prophenom, which is the general nursing care. It will show that you are nursing a patient who requires emergency interventions. But if they have said the patient has cerebral malaria and you start with a prophenom, no one is going to mark that management because it doesn't make sense. That patient is already dead. So basically, that is how you can manage a patient by prescribing such drugs and doing all those interventions to that particular patient. So look out for other lessons. This is where I'll end with today's lesson, and my name is Urod. So thank you so much for taking time to go through today's tutorial.